We're at the IAS meeting here in Vancouver, BC, and we're here with Anna Grimsrud, who is with the University of Cape Town, South Africa. And you're going to be talking about the support groups of sorts.
Right. We have a patient model of care called adherence clubs, and in Cape Town, our adherence clubs at one facility are totally out in the community. They're based at a community center. So stable patients don't have to go to the clinic anymore. They can receive all their treatment and care and support out in the community.
And give me a picture of what that how it evolved, maybe, first of all.
Sure. So when antiretroviral therapy first came to resource-limited settings, we imported not just the drugs, but also the way in which they were delivered. So they were very doctor-centered and hospital-based models of care. And over time, for a number of reasons, but largely because of science and evidence, we've transitioned how we provide treatment. So we've moved it to being more nurse-centered, more based at community centers, and now there's a real need to move it even closer to patients' homes. And so that's kind of where the idea for adherence clubs came from.
So when you have an adherence club, that's where people pick up their medications or as a group? Or
Yeah, as a group. So it's a group model. So approximately 30 patients who are stable, meaning they don't have any detectable virus in their bodies. The same 30 people meet every 2 months, and at that meeting they have a peer counseling session from a community health worker. They have a brief symptom screen, they're weighed, and then they do receive pre-packed ART at that time. Yeah.
So not only are you you're setting a standardized time to get the meds. Do you do any investigation as far as whether they have any meds left in the other bottles, or do you do
No, so that's the real shift. So if patients are seen at a facility, they have an individual counseling session where they do things like a pill count. But now these patients have been deemed stable, and so we don't do any sort of individualized kind of counseling or adherence support unless they request it.
So how many of these do you have already set up?
So at the clinic where I work in Guguletu, we have over 80 clubs at the moment, reaching 2,500 patients. And in the Cape Metro, which is the health district in and around Cape Town, there's more than 30,000 patients, or a quarter of everyone on treatment, who's receiving their care in this way through an adherence club.
Now, when you say an adherence club, this is just a group of what, 30 people or so? And that's all there is to it. There's this one group that meets once a month and gets their treatment and a counseling and a group session.
Right, so they meet every 2 months.
Every 2 months.
And they actually meet 5 times a year, because at the end of the year, our population is very migrant. You know, they go home for the holidays.
Right.
And so to ensure that they don't have
They get an extra
They get an extra 2 months, yeah. And so they meet 5 times per year. So there is a level of peer support that happens because you're seeing the same 30 people. And also they have very close relationships with that community health worker. So it's the same community health worker that they see every time they come. And that's someone who lives in their community as well. So you can bet that if they don't come and that person runs into them on the street later that week, they are going to feel this social pressure also to be coming back to the facility, not the facility in this case, but to their club. So they are getting more than just drugs. It isn't just a pharmacy window.
Now, is the group constructed of, say, for instance, a man and wife and maybe kids who would also be taking treatment, possibly? Would they all come to the same group, or?
So at the moment, most of the clubs are just adult clubs, and so we do see couples, friends join the same club or ask to be transferred into each other's clubs. There are examples of pilot projects for things like family clubs where children come with their caregiver, and it's obviously an effective way of getting both of them their treatment if they're both on treatment. But these clubs are not driven by the patients themselves, in the sense they're not self-forming groups. So they're actually a random group of patients whose common characteristics would be that they're HIV positive, that they're virally suppressed, and that they live in the catchment area of the clinic. But where I work, it's very dense. So 70% of the patients live within 3 kilometers. So in an urban setting, we haven't had the need to kind of expand and offer geographically based models of care. In some of the more rural areas where my colleagues work, those models have done that. They've said, let's make the clubs based on where people live and where they reside, because that makes sense because their challenges are maybe transportation related then.
And what is the outcome that you've been able to establish?
Right, so we obviously take good patients and make it easier for them to get their treatment. So they do well, which is not surprising. So after a year, 94% of them are still on treatment and 98% of them are virally suppressed. And so in that way, it's a very efficient and effective model for the patients. What it's also allowed us to do in the Cape Metro is that the program has doubled in size. The ART cohort has grown from 60,000 to 120,000 patients in 4 years without any additional financial resources. So it's allowed for the program to grow. So there's benefits not just to the patients, but to the health system and then the new patients as well, because we make a space for them, so to speak, at the clinic.
Sounds like a winner.
Yeah.
Yeah. Well, Anna, I appreciate you taking the time to come and visit with us. And I'm hopeful that maybe you can give another report down the line and letting us know how things are going or expanding or replicating in other areas and so forth.
Exactly. That's our hope, is to encourage and support implementation in other contexts.
Great.
Yeah.
Thanks again.
Thanks very much.
Thank you.